Hello everyone, my name is Frédéric Michard. I'm from Lausanne in Switzerland. And so before I start, I'd like to disclose the fact that I'm today leading a consulting and research company based in the Swiss Silicon Valley and where we focus on digital innovations with medical applications. I also want to disclose the fact that I don't have a crystal ball. So I don't know exactly what will be the future of hemodynamic monitoring and more specifically of cardiac output monitoring. But at least I can share with you my vision, the vision from someone with clinical research, but also industry experience. And I will start by discussing cardiac output monitoring in the ICU. And to better predict what may become available in the future, it's interesting to have an idea of what are the current trends. And I think this is the most recent snapshot of hemodynamic practice in the ICU. This is a survey published a few months ago with a focus on COVID-19 patients. And one of the main findings of this survey that echocardiography is today widely used in intensive care units for hemodynamic monitoring. It is used, of course, to assess cardiac function. We knew that. But what was new is that it was ranked number one for the prediction of fluid responsiveness, number one for the assessment of the quantification of pulmonary edema, and also number one for the measurements or monitoring of cardiac output. We observed a few differences between regions, but with regard to cardiac output measurements, actually echo was ranked number one in the three main regions we surveyed. So there are several reasons to explain this, I would say, enthusiasm for echocardiography. The first one is that echo devices became much easier to use than in the past. They were miniaturized and they very often fit in your pocket. Actually, I suspect some of you even have simply a probe in your pocket you can connect to a tablet or a smartphone. And it's pretty convenient, as you know, to do or to perform qualitative evaluations, to look at left ventricular contractility or function, to detect right ventricular dilation, or to detect significant variations of the IVC during mechanical ventilation. What's missing on these tools is a pulse Doppler for measuring cardiac output, and we can bet it will become available far before 2050. What made the success of echo, I think, is also the fact that software have been developed to facilitate the acquisition, but also the interpretation of images. Smart software and machine learning algorithm. So this is an example of an existing smart software helping clinicians to properly measure the VTI at the level of the left ventricular outflow tract. So you see there is a small green square around the caliper, and so actually it would be yellow or red if you were not correctly positioned. This is a similar software able to automatically or almost automatically quantify VTI, cardiac output, and even SVV, which is stroke volume variation induced by mechanical ventilation. There are possibly more on the market. Artificial intelligence may actually further help for echocardiographic evaluations. And this is an example of a machine learning system that was recently developed, able to assess left ventricular ejection fraction without even the need to measure ventricular volumes. And you see here on the left-hand side, the measurements are done by the machine learning system compared to measurements done by clinicians on the right-hand side. And you see the machine learning system was at least as good as clinicians to assess ejection fraction. Machine learning systems, you know what they are. They're actually algorithms we can train to recognize specific patterns or specific phenotypes. And so they may help us not only to measure hemodynamic variables, but also to interpret images obtained from echo. So the introduction of artificial intelligence in echocardiography, it's not only to guide us for image acquisition and optimization, It's also a potential help for analyzing and interpreting echo images. Another trend is the increasing use of wearable and wireless sensors. In other words, to monitor patients beyond the ICU, because we know these patients are actually pretty fragile and at high risk of clinical deterioration. So one of these sensors is actually a smart necklace developed to monitor vital signs, but also recently approved by the FDA to measure cardiac output. So it may be used, of course, to monitor patients after an ICU stay, but also before surgery to assess individual or personal cardiac output values. And you may have seen this recent paper from the team of Bernd Sogel, recently published in the British Journal of Anesthesia, where they quantify personal cardiac output values before surgery and use this personal value as a target during surgery, and reported a very impressive improvement in post-operative outcome. So that's possibly what we will do in the future as well, using non-invasive and easy-to-use cardiac output monitoring or measurement systems to determine personal cardiac output values before surgery. But let's go back to ultrasound innovations. In 2050 and before, we'll have the opportunity to use wireless Doppler patches. And this is an example of actually an existing product that was recently developed by a Canadian startup. So you see what it looks like, and it's something you can use to monitor continuously carotid blood flow or blood velocity. We use in sensor in this study published earlier this year, where we compared changes in carotid blood flow to changes in stroke volume during a preload modifying maneuver, and showed that there's a pretty good agreement between the two approaches, the two methods, suggesting that in the future it's going to be easy to predict fluid responsiveness, for example, using these adhesive Doppler patches. Let's switch gears and discuss now what we need or what we will use in the OR for monitoring cardiac output during surgery. We know today that the preferred choice for anesthetists is to use a pulse contour technique. We know that from very large studies. On the left, you have the YOZO study, containing, as you probably know, over 45,000 patients from 27 European countries. On the right, you have the RELIEF trial with patients coming mainly from Australia and from the US, over 3,000 patients. And so in these studies, when we look at which techniques were used by anesthetists to measure cardiac output, clearly they were used mainly pulse contour techniques. We know they are easy to use. You just have to connect the sensor to an existing radial line. But most of them are uncalibrated, and we also know they are not as precise as reference methods. But in these meta-analyses, we showed that when anesthesiologists were using these pulse contour techniques, it was associated with a significant decrease in post-operative morbidity. You see the odd ratio was 0.46. A pulse contour technique is actually an algorithm able to compute stroke volume from the blood pressure waveform. So there is no reason to think that this algorithm could not be uploaded or installed on any computer or any box we use already today at the bedside. So I bet that before 2050, bedside monitors will contain pulse contour algorithms, so that any monitor able to display a blood pressure waveform will have a pulse contour algorithm inside, and then we'll be able to provide continuously advanced hemodynamic variables. Today, this blood pressure waveform usually comes from a radial catheter, but tomorrow it may come from a non-invasive system. And you see here a summary of existing non-invasive systems, but clearly in the future, we'll use different sensors. And these are a few examples. This is a new micro-electromechanical system. It's part of a small bracelet able to record a radial pressure curve. And you see here the example of a comparison with an invasive measurement. Thanks to flexible and stretchable electronics, we will be able to use these kind of ultrasound patches to measure blood pressure. Of course, the idea is not to position it on the joint as on the picture, but it's just to show you what it looks like. That's something you would put on a big artery, on a carotid artery, on the brachial artery, on a radial artery to measure blood pressure. And this is different. It's a piezoelectric sensor, but the principle is the same. The idea is the concept is to have a small wireless sensor able to basically feel your pulse and display high fidelity blood pressure waveforms. So it's coming. So to summarize what I said so far, the future of cardiac output monitoring, as you can see, is AI, but the A would stand for automation, the automation of the acquisition of echo images, the automation of the measurements of hemodynamic variables with echo, and the automation as well of interpretation. And the I could stand for integration. I mentioned so far the integration of pulse control analysis into bedside monitors, but we could also envision to integrate into mechanical ventilators the CO2 rebreathing method, which has been recently revisited and is now named the capno tracking or the capno dynamic method. So this is an example of the capno dynamic method. And this is a comparison with reference method, an aortic flow probe, and pulmonary thermodilation. And you see that this capnodynamic method seems to track pretty well acute changes in cardiac output. And this is another example of the capno tracking method, a study from Philip Patton from Melbourne, showing that this new approach based on CO2 elimination is pretty interesting or promising to measure cardiac output as well. So clearly, in the future, we can bet that mechanical ventilators will integrate this kind of algorithm to compute cardiac output continuously or almost continuously. Anesthesia machine, finally, of course, will have the option to give us cardiac output either from capnodynamic or the capno tracking methods or simply from a pulse control algorithm. So cardiac output should be available in the future on an anesthesia machine without the need to use a specific dedicated hemodynamic monitoring system. When I mentioned integration so far, I meant integration of pulse control analysis, of capnodynamic software into existing devices, but it's also data integration. It's the idea or the concept that a single cardiac output value is not very meaningful. It has to be integrated into additional information. What are the determinants of cardiac output? What is the adequacy of cardiac output? And so data integration, data fusion, and also the way we deliver the information to clinician will change. And as you know, we'll use more and more graphical display. And you have seen, I mean, actually the evolution already over the last 10 years. Basically, all hemodynamic monitoring companies developed graphical display to facilitate the understanding of what's measured and to help clinicians make therapeutic decisions, to have actually a more holistic view of our patients. And so in the future, this data integration, data fusion, and the use of graphical display will make possible the suggestion by the monitor of a diagnosis of therapeutic options. And of course, the graphical information will be useful for the early detection of clinical deterioration. So in conclusion, in 2050, and probably before, we'll have pulse Doppler on pocket echo devices. Smart software and machine learning algorithm will help us to optimize the acquisition of echo images, but also, and probably more importantly, to interpret these images. We'll have the opportunity to use wireless Doppler patches to track changes in cardiac output during, for example, preload modifying maneuvers. Bedside monitors and anesthesia machine will integrate pulse control algorithm. Mechanical ventilators and anesthesia machine will integrate CO2 rebreathing methods. Finally, data integration and fusion, as well as visual decision support tools, will help us to make the best therapeutic decisions for patients with hemodynamic instability. And with that, I thank you very much for your attention.